Okay, Roman. Hello again.
Hey.
Okay, so um, we have a question on YouTube. Somebody asked a question today, and I thought I'd would pick it up, and it actually coincided with something that I thought I should be clarifying, or maybe spend a little time. The question goes like this. I'm going to paraphrase a little bit. Um, the person asking the question says one part that I questioned was the example of the gold standard with COVID-19. He says, I understand the point, but it seems to me that even if there is no gold standard, there can be enough data gathered to identify what is the normal variation of the disease, which we can compare other cases against. Um, and then he says, yeah, I'm not sure that the question is not articulated perhaps very clearly, but I think um, he's hinting at the idea that we can, I mean, even though there may be not be any gold standard, we can get a sense from, he says, accumulating, from seeing a lot of
Right.
from data gathered, to see what sort of the range of normal is, or the range of variation for a certain disease is. And I think that's correct, uh, but it still doesn't, that in and of itself doesn't um, define, um, strictly speaking, the borders of what a disease is. Um,
Right.
from gathering data, and I'm going to
I mean, you talk about that in your book, right?
yeah, correct. I mean, it's essentially you're getting ahead of me,
Oh,
because
okay.
essentially that's where I was going to go to a little bit, or talk to that to that point a little bit. So if you take the mechanical view seriously, if you really think that we're made of parts and the parts are the real stuff, and that everything else comes from that, the mechanical worldview, that we're like clocks, or biological clocks, functioning clocks,
Yeah.
and whatnot. If we're healthy, we're functioning clocks. If we're not healthy, there's a defect, and there's a problem with the functioning of the clock. If you take that very seriously and try to run with it, you get to what is known in medical philosophy as Boorse, I think it's Boorse, Christopher Boorse theory of disease. So Christopher Boorse is a philosopher. He's not a physician, but he got interested in the question of health. I think he's still around. He teaches at the University of Delaware. He's been there for several decades. His big splash was in the late 1970s. He published a paper, Health as a Theoretical Concept. Um, and he, I mean, at the outset, he says, I'm going to be very strict. I mean, I believe that I'm a reductionist. I'm a material reductionist. I believe
Hmm.
that everything that exists is the little particles, and everything has been assembled according to, evolutionary theory and whatnot, to what we have right now. And that's really how we need to consider the concept of health. And the concept of health should be the same for human beings as it is for animals and whatnot. I mean, there is a norm, and that norm essentially is a statistical norm.
Hmm.
It's going to be that within a narrow range, there's some variability in whatever aspect of physical aspect you can consider, and if you deviate too far from that, then it's pathological. So this is actually, I don't know if you see it. Maybe I should have uh, made it a little bit bigger, but this is from his paper, from his initial paper, and he wrote. He kept on developing that theory. So essentially, he used the normal curve as a paradigm for what is healthy. Okay, so
Hmm.
healthy is really normal functioning, and there are some cutoff points beyond which it is not functioning. So
Right.
it's some arbitrary. I'm not sure how he determines what the criterion for
The cutoffs
the
are.
cutoff is going to be,
Right.
but he says, there is. I mean, there are such. I mean, and maybe they're arbitrary. I mean, maybe he says they're not. Um, they're not clear cut, but that's the best we can come up with. We have to come up with certain criteria of efficiency, and then beyond that, it's abnormal. And it's really efficiency per function. So if a rabbit,
what does he mean by that, right?
Right. So if a rabbit is an animal that it's a rodent, right? So it chews wood.
Okay.
So its chewing efficiency has to be, is within normal. Yeah. So you get a bunch of rabbits. They're going to vary around
for a certain age, for a certain
correct,
color.
Exactly. So the chewing efficiency of the rabbit is going to vary within a certain band, and beyond that, it's no longer efficient. And I suppose it's no longer a rabbit, or it's no longer a healthy rabbit, right? And so a rabbit is not just a chewing thing. It's also a thing that reproduces. It's a thing that digests. It's a thing that hops around. So it has a hopping efficiency. It has a chewing efficiency. It has a, anything you can think of about a rabbit. It has a temperature maintenance efficiency. It has all these things. And every single thing you can think of can be plotted out on a normal curve, because within that species of rabbits, you're going to have variation in all of these things. And then if you essentially, I suppose, you aggregate them together, that gives you the rabbit and the normal rabbit, and which is the healthy rabbit. I think it's hard to defend, but you can see that some people could push it that far. It's hard to defend because it doesn't. First, it doesn't distinguish a rabbit from a non-rabbit. It doesn't really tell you how you get that.
I mean, they would argue probably that just the variation will be different. And so if you were to have all these schematics and you were to reproduce them, you would end up reproducing something that's not a rabbit if you had different parameters.
Right. But the thing is, we start off knowing what a rabbit is. Right. We don't start off with the normal curve. We're going to select. In fact, in order to construct the normal curves, you're going to pick out rabbits. So it seems that we already know what rabbits are, and we must know also what a healthy rabbit is. And I don't think we know that from the curve. We don't know that from collecting 1,000 rabbits and plotting those curves for every single parameter. So I don't think it holds up. Right. I wrote a little paper. I go into this a little bit more. It has to do with it's a way of critiquing Christopher Boorse from an Aristotelian perspective, which the Aristotelian philosophy will bring in some concepts that allow us. You may agree or disagree, but I think it's correct. But it allows us to make the distinction between a rabbit and a rat, or a hare, or another kind of things. And also within a kind, it helps us sort of distinguish what is healthy and it's not healthy. But I don't think it cannot be just a mathematical function. Number two, the normal curve, the way he draws it on his thing is incorrect, because the normal curve goes to infinity on both sides. It doesn't cross the y, right, the x-axis. Mm-hmm. So, well, I mean, I'm not saying that it's not. The fact that he chooses arbitrary cutoffs, I guess, is where the arbitrariness of the point. Yeah. At any rate, so accumulating data for the reductionist, for the Cartesian materialist, may seem like it can give you a sense of it can give you some kind of, it can give some order, it can give a form,
it can give you an idea,
it can give you it gives a form to your experience. It gives a form to what you see. It gives a mathematical form to what is out there. but it cannot define it. It cannot define what is healthy, what is not healthy.
There's a level of subjective data that will always be missing. So
right. Well, except that I don't think it's subjective. So that, I mean, that's the difficulty, is that I think the data is out there, but I think it's not subjective. I think we recognize it. For example, a wolf will or a fox will recognize a rabbit and will be able to distinguish a rabbit from a rat, or in a certain sense. I mean, we don't know exactly what goes through the mind of the fox,
right?
But the fox can make distinction. The animal can make distinction. So it doesn't have to be a human mind. So it's not entirely in the human mind. So I think there's something about the health of the rabbit that is in the rabbit, but it's not exclusively in what is observable.
Right, that's what I mean. Right. It's non-reducible.
Correct. So, it's not reducible. It's not exclusively in what is observable.
I could give you the exact proportion of hydrogen, zinc, iron, whatever in your body, but I wouldn't be able to reproduce Michel Acad.
Right. I mean, that would be the idea. So in medicine, so if we go back to COVID-19, the gold standard, the gold standard of what is a normal person, or what is the gold standard of COVID-19? Well, COVID-19, again, it's COVID-19 is not a real thing. It's not like a normal human, a healthy human being. So a healthy human being admits of variations, but it's there, and it's real in the way. It may not be actually. That's another quirk. It may not be, perfect health may not be instantiated in anybody, right? In a certain sense, at least in a certain sense of health. So you have to distinguish here between the practical sense of health and the maybe the theoretical sense of health.
Right. As soon as you're born, it's all downhill from there.
Correct.
You don't get healthier.
In a certain way. You don't, but at the same time, so for physicians, we are practical. We're in the realm of the practical. So in terms of practical health, it is there. It is something that we can decide, we can determine whether it's present or not. And likewise, I mean, the patients in front of us can help us in that determination by expressing their experience and how they feel. But COVID-19, is there a range? So there's going to be a range of things that we call COVID-19, but COVID-19 adds a layer of arbitrariness because it's a deviation from health, and it's a deviation from health in a certain pattern. But the temptation is going to be to formalize that pattern. Again, according, if we are mechanical about it, we're going to use these curves. For example, if we're going to say that to have COVID-19, you have to have A, B, C, D, and E. And A, let's say, you're going to have a cough, or you have to have a cough. Well, what does it mean to have a cough? Well, everybody coughs a little bit. Okay, well, it's not just a little bit. It's going to be more than a little bit. It's going to be a cough that is, I mean, the mechanical view, if the mechanical view views COVID-19 as inhering mechanically as a real defect in the body, is going to start to look for sort of very, if not precise, at least narrowly defined and or
it
normally
to fall
defined.
Apart when you realize how many different normal curves you're going to have to construct, and then you're going to have to make an arbitrary decision of cutoffs, and then an arbitrary decision of how those cutoffs compound together into some compound normal curve that then is used for some cutoff for prescription diagnosis. It starts to quickly fall apart.
Right.
If not theoretically, then at least practically.
Exactly. That's exactly right. Because there cannot be anything because there's that element of arbitrariness that some, where you draw the cutoffs, and then which of the curves you do. Do you have a curve for cough, or do you include cough or not cough, or why do you include cough, or why not do you
Or how much
include cough, and
coughing.
how much cough do you include, and all that stuff, and how much fever, how much this, how much that. So at the end of the day, it remains kind of an intuitive thing that the human mind can, and um, so it's not formal. It's not. It cannot be put sort of mathematically with on the basis of mathematical formula. At the same time, it doesn't mean that it's not real. It's not out there in the patient, and it doesn't mean that we cannot relatively easily come to agreement among ourselves as to whether something is COVID-19 or not. But it remains in the realm of judgment. It remains in the realm of judgment, which means that it's first of all, there can be disagreement, number one, and number two, it's not going to be discovered or detected by any kind of specific procedure.
I think it's important to clarify here your point about the difference between a case and a positive test. I know you've been emphasizing that recently.
Right. So the case, I mean,
because I think the quick, easy rebuke would be, you do a test, and if it comes back positive with, then it's COVID, and if it comes back negative, then it's not COVID.
Sure. So the positive test. So then, if you have a test that is super sensitive for the detection of the virus, so here we're just talking about the viral agents being discovered in proximity to a body, say in a nasal cavity, right? And if you have a test that is sensitive enough, it's possible you may not even have an infection. Maybe you just have, a single particle that happens to be sort of lying gently on the nasal hair of the patient, right? I mean, if you have your test that is really of astronomical sensitivity. Now, in most cases, I think it's going the practical controversy is going to be about whether the tests are not that sensitive, but they can pick up people who are otherwise feeding perfectly well. And so what you may have, at least for a period of time, a symbiosis between a viral particle and a human being, right? And why would you decide to call that COVID-19? Well, the only reason you would decide to call it COVID-19 is not for clinical purposes to take care of the patient, but it'd be for epidemiological purposes, for things that are public health, things that fall outside, provided you know what to do with that information. And I think it seems right now, at least, dubious that we know what to do with that information. As opposed to waiting for a certain pattern of ill health, right, or a deviation from what we apprehend to be healthy, to declare itself in the patient, and then decide to call that COVID-19, and make sure that you're careful and you distinguish this from, again, because people can be unhealthy in multiple ways at the same time. You distinguish that from something else that produces a cough and maybe produces a temperature, and maybe coincidental with the presence of a virus in the nasal cavity, and COVID, right? And so it's very tricky, right? It's very tricky, and so the procedure is not cannot tell you by itself. If you call it COVID-19, if you limit yourself, strictly speaking, to calling everything that is PCR positive COVID-19, you could do that. But what you will achieve, I think, will make people unhappy at the end of the day, right? I mean, what's going to be the what is going to be the litmus test for whether it's a wise thing to do, to call every PCR positive case a COVID-19? It turns out that you're going to have to add something else to that. You're not going to be able to limit yourself to that, right? Because, again, I mean, that diagnosis has to serve a purpose. The diagnosis is to either help the sick or help the population or whatever you do, but it's going to require an intervention. And if you limit yourself to making the diagnosis just on that basis, that means that you're going to treat every single COVID-19, PCR positive person in a similar way, and we know that that's not the case. So you're going to have to invoke other things that are not going to be a process of detection. You're going to have to enter into whatever else you do some level of judgment, which hopefully will be on the basis of something that is real, that happens in real life, in real persons and whatnot. So
right, it's like this interpenetration of whatever you may call a normal curve starts to create impossible problems that you can't really calculate your way out of.
Correct. And again, thank God we really don't do that even today. I mean, as strictly as, even if we want to, which is what I said in prior episodes, we blend in, some scientific procedures with our clinical judgment. And for the most part, I think even today, despite all the problems, there's quite a bit of clinical judgment that comes into play in what we do. So that's that. Anything else for now? I don't have anything more to share with the slides, but I thought we'd talk a little bit about some questions that you and I talked about last time. So you asked about, practically speaking, what does that mean for how we practice medicine, how medicine was practiced in the past, and maybe we can start there. And you asked about what happened at the time, around the time of Descartes, and things like that. It's a long story, and it's kind of a nuanced story. And I'm going to recommend, at least for those who are interested, I think a book that is really terrific. I'll show it here. I'll have it maybe on the YouTube show notes. It's a book on Hippocrates itself. So if people are interested in understanding Hippocratic medicine and what it was in practical terms, the author is Jacques Jouanna. Jacques Jouanna is a French classicist who specialized in medicine. He's, I think, the authority nowadays. He's near retirement, but I think he's still pretty active.
Here's my coffee.
Okay, very good. Yeah, I think it's terrific. So there are interesting things. Maybe we can start there. So I can speak a little bit about what I learned from Jouanna's book about Hippocratic medicine and how astonishing its development is. Hippocrates himself, as far as we know, was a real person. There's no text that exists that we can trace back to him. There are texts that are called the Hippocratic texts that have survived, either completely or in fragments. And these, they've survived because in antiquity, in late antiquity, later on, they were preserved and copied and disseminated, notably at the library in Alexandria. They were kept there, and then and then Galen himself, who was very prolific. So Galen, we're talking about 2nd century AD. Hippocrates, we're talking about 5th to 4th century BC in terms of time period. So Hippocrates came from an aristocratic line called the Aesculapians. The Aesculapians were kind of a priestly caste in ancient Greece. Asclepius in the mythology is kind of a demigod, so that line of that caste, if you will, traced its lineage back to a mythical figure, Asclepius, who may have existed, but maybe his life was mythologized as being a demigod in times past. But the focus of that religious caste was healing. So it was sort of a healing religious family that passed on its medical practice. And the medical practice, to the best that we can tell, was probably a combination of religious rituals, right? And there were some centers where Asclepian offerings would be given to the gods for the sake of healing people who would come to those places. So there's a mixture of religious ritual with sort of um, folk medicine, if you will. Things that have been learned by human beings since time immemorial about remedies with foods or herbs or whatnot, or some kind of things that would help people feel better. Okay, so that was the Aesculapian families into which Hippocrates was born. And the Aesculapian families there were three centers in three islands in the eastern Aegean Sea, near Turkey, near present-day Turkey. One was in Rhodes, one was in Kos, the island of Kos, and a third one was in the island of, I'm blanking out on the name, but the third island. But both Rhodes was eclipsed very early on. Kos is the one that really, in which the Hippocratic medicine was born and flourished. And the second island, I can't remember it, but it remained primarily a kind of a religious center. So out of Kos, we don't know why, we don't know under what circumstances, formed a completely a radical departure from what preceded it. So formed a school of medicine centered around a man named Hippocrates, to the extent that we know, that started to look at the question of health and illness in much more rationalistic terms, as opposed to religious terms. Not that they were atheists; they were still, as far as we know, religious people. We certainly know from the Oath, which is one of the texts that we've retained from then, that the Oath itself was an oath made to the gods, to Asclepius, to Apollo, to other gods. And so they were religious people, but certainly in their method, in their approach to treatment, to diagnosis and whatnot, they were extremely rational. They were looking for naturalistic explanations, and so they formed a school, and there was a body of knowledge that was passed on from generation to generation. I think it's, from what we've talked about regarding Hippocratic medicine and medicine, meaning this attention, first of all, to the whole individual, to the sick person, which is in the Oath, it's natural that they would remain kind of generalists, right? So Hippocratic medicine it's essentially family medicine, even though their body of knowledge did subspecialize. I mean, there are treatises on fixing joints, there are treatises on the gynecology, right, the illnesses of women. There are treatises on epidemics, which they didn't have the germ theory of disease, but they were plagues that would come and affect a city or a countryside or whatnot. So, but nevertheless, the Hippocratic physician himself, and they were male as far as we know for the most part, were generalists, family physicians. Some of them may be itinerant physicians, and they might go from town to town. And we certainly know that Hippocrates himself, to the best that we can reconstruct his life, moved from the island of Kos and traveled to Thessaly in northern Greece, and established. And so they were followers of that school that went and spread around Greece and Western Turkey, present-day Turkey, and sort of that part of the world. And they established, if they settled in a city, they would settle and establish a private practice. So a practice, and they might make house calls. We know from the text that they would go to the house. We certainly know it from the Oath and whatnot. They would make house calls, but they also had a practice.
Professional.
They were professionals, correct. They were absolutely professionals. I mean, they were professionals by professing the Oath, right? If that was
but it was more than just a philosophical stance, let's call it.
Yes, correct. There was a trade. They were artisans in a way. I mean, there was a skill or craft, if you want to call it a professional craftsmen who profess something, who take an oath of conduct, and which was, I think, unique to medicine at that time. Later on, it was adopted for other professions, maybe the legal professions and other places as well. But I think it started in medicine. And so they had a practice. They had maybe an apothecary, a place where they would keep herbs and distill their purgatives and whatever else they might treat patients with. Um, but they and I don't know if we talked about it in the previous episodes, but there was certainly in the theory of no, I think we did talk about it. We talked about the fact that they view the whole body as kind of a self-regulating thing, right? So there was something about nature that was self-healing. Okay, so the role of a physician generally was gentle. It was to provide. So even if they did a little bit of bleeding or bloodletting or purgation or any of these things, it was not very severe as far as we can tell. It was pretty mild purgatives that they would administer. That will change later on, as we will see perhaps in a moment. But they were it was fairly gentle. Okay, the only thing where they might be it might be a little bit more sort of aggressive would be in how they dealt with joints, try to set a joint back in place. But even then, I think by certain standards, it was pretty gentle. In fact, it seemed to be more gentle compared to contemporary Egyptian medicine. We don't know much about Egyptian medicine except for we have very few fragments, but there are some fragments that come. But it's an interesting contrast to talk about um, right now. At least it interests me as far as the politics of medical care are concerned, um, because it's clear that Hippocratic medicine was a completely spontaneous emergence. It was not something that was in any way commanded by state or city authorities or regulated by state or city authorities. Okay, it's completely spontaneous as far as I'm concerned. You may call it free market. I can call it I call it free market, but free market has sort of an economic connotation. But essentially, it's a voluntary free emergence of a certain practice. Egyptian medicine is not at all, so far as we know, is a very much a state regulated procedure. And the physicians were state employees. Not everybody could be a physician, right? You had to be to be given that privilege by the state. We don't know much about its theories, but I mean, maybe I'm projecting my own biases into it, but I think it was more mechanical. It
Do we
certainly
not
was.
know about it because Greek medicine replaced Egyptian medicine when the
No,
Macedonians
well,
came in? Or?
we have some texts, some Egyptian texts, but they're not philosophically as developed, or as we don't have as many texts as we do Hippocratic texts, right? There are only a few fragments of Egyptian texts that we have that have been translated, and I don't think um, they sufficiently amount. There's things that are said about Egyptian medicine which is interesting, which is contrary to Hippocratic medicine. Egyptian medicine was extremely specialized. So that's, to me, that sort of speaks to kind of a mechanical view of things, because you had the brain physician, you had the dental, right, the dentist, the tooth physicians, you had the liver guys, and they were extremely specialized, and they only dealt with their own organ system. So in a way, by definition, that's kind of mechanical. I mean, it's not mechanical in the Cartesian sense, but it's at least it doesn't view the individual with the same respect that we view individuals nowadays.
Right.
And
To a
the same
certain
respect
degree,
that,
you could say that the Egyptians, having built the pyramids and so on, were a much more technical society up to that point. I mean, the Greeks have their own, architecture and so on, but this has been ingrained into Egyptian society for thousands of years now.
Correct. That's correct. And there's no philosophical tradition in Egypt that has survived that we know of. Certainly not to the extent that it was present, and I'm sure it played a role in the emergence of Hippocratism, the Greek philosophical tradition, which preceded Hippocrates by 100 to 150 years, was around, and I'm sure was necessary for Hippocrates or his followers, whoever it was, to all of a sudden say, well, let's move away from this totally religious orientation to medicine, and let's start to think about natural causes as being operative in the way the body becomes ill and heals itself and so forth, and can be treated. So you're correct. I mean, I think, and why did philosophy, at least Western philosophy, emerge in Greece as opposed to other places? I mean, who knows? But you're right. Um, uh, Egypt was highly technical, highly autocratic, highly hierarchical, and highly this and that, and that's reflected in medicine as well. So Egyptian medicine was very, very, and was very violent as far as we know as well. Was quite violent in its approach, and we know that perhaps from texts that speak of independent third parties. So you had the Persians. Persian, and there are stories about Cyrus or some other Persian prince who there's a story that's repeated where he had a broken ankle. He fell from his horse, had a broken ankle, and was first treated by Egyptian physicians, and it was evidently not a very pleasant experience. So then he dismissed them, and then among his prisoners were some Greek physicians, and then he asked the Greek physicians to take care of his ankle, and that seemed to be a more a more pleasant, patient-centered experience. So
I mean, it makes me think about the fact that just mummification demands almost a really detailed and sort of aggressive knowledge of the body.
That's true. It does, but in a way that it demands aggressive knowledge of the body inside out, right? Which is something that the Greeks did not do. So the Greek physicians did not study anatomy.
I was going to ask about surgery. What was the Greek situation with something more invasive like surgery?
Correct. So the oath offers a particular mention to that, where there's which is ambiguous and still is being debated among scholars to this day about what's the meaning in the oath, when in the oath the Hippocratic physician says that he will not let me read it right now here.
That's right, that he won't.
It's not a rejection of the knife
or something like that.
Let me read it right now. I think it'd be easier rather than to here we go, the oath. I need to take my glasses off. I will not use the knife, not even verily on sufferers from stone, presumably kidney stone, but I will give place to such as are craftsmen therein. So I will not use the knife, but I will refer to the surgeon. Not sure why. They would set joints. The Hippocratic physicians would set joints that were out of place, but they would not use the knife. There is...
is that a religious reason, maybe?
I don't know. I don't think anybody has... there are theories that... my own theory is maybe because there might be a conflict of interest if you're going to be the physician and the surgeon.
Okay.
But it's a weak theory. It's a weak argument. But I don't think any of the other arguments are necessarily stronger. But
surgeons did exist, and they were separate from physicians.
Correct. Well, yes. I mean, certainly, again, if the Hippocratic strand comes from a religious caste, maybe that religious caste did not, they did not get their hands dirty for religious reason. Perhaps you're correct, but they did offer sacrifices and offer herbs and other treatments, like that. So I'm not sure. I don't know that we know for sure. But they were not, and perhaps because surgery required some specialization. But there's some aversion to surgery, and if not an aversion, it's not a complete aversion, because they agree to refer, which is unlike the case for assisted suicide, which is also in the oath, right? In the oath, they would say, "I will not assist, nor refer, somebody to commit euthanasia." Let me read it here. So it seems to be a stronger prohibition against suicide than it is against surgery. So where is it? I lost my page here. Sorry. Here we go. The oath. So they're willing to refer to surgery, but But in terms of neither will I administer a poison to anybody when asked to do so, nor will I suggest such a course. Right. So they want to make they strongly they will not refer for somebody to be killed, either for their own, for their own wishes, if they want to commit, or to work at the service of a third party to kill somebody. Um, so I'm not sure why the separation between surgery and medicine is, but it is. It exists and existed since then, which is not the case with the Egyptian physician. And again, the term physician is properly Greek because it refers to physis, which is nature, right? Mm-hmm. It refers to human nature. So it's properly Hippocratic. Whereas the Egyptian, I mean, I don't know how we may translate the term now as physician when we talk about Egyptian doctors, but properly speaking, they were all specialists from the get-go. And so it was the brain guy and the liver guy and so forth. So that's, as far as we know, that's Hippocratic medicine, which flourished around that time, and then the school itself was eclipsed in late antiquity, in Middle Antiquity, when the Greek city-states sort of fell apart and came under the dominion of the Macedonian Empire, Alexander the Great. And after Alexander died, and when the empire was split into four, the Ptolemaic empire in Egypt, gave rise to the Library of Alexandria, and to, again, a state. I'm me politically. I'm sort of aggressively. You might say libertarian, but for anarchy, right? Perhaps anarchist, but it's the state. It was the Library of Alexandria is a state-sponsored institution. Mm-hmm. Okay, so it's a state-sponsored institution, and it demanded, and it founded, the foundation of the School of Medicine of Alexandria, which eventually eclipsed the Hippocratic School of Cos, gave rise to a very aggressive kind of medicine. So the famous physicians of that time engaged in, and they were much more what we might recognize as scientific, much more prone to conduct dissections, and not only dissections. I mean, there are actually reports that they engaged in vivisection of prisoners to study the body, right? So they view the body much more as a something to be, to be mastered and studied intricately, a little bit like a machine. Again, the mechanical paradigm of Descartes would not see the light of day but it's kind of a precursor. I mean, it certainly is. It's
we're seeing Egyptian norms being absorbed into Greek practice.
Yeah, perhaps. I'm not sure where that came from. I mean, those were Greek-speaking people. I mean, by that point, Alexandria was kind of a Greek city, right? Even though it was, so I'm not sure how much remnant of the, but you're right. I mean, there must have been kind of an interbreeding of these two cultures. So you have the Greek, the late Greek, the school of Alexandria, much more aggressive, and then you have this dispute between the various schools, between the dogmatist schools and the empiricists and the whatnot. Maybe we'll get into that sort of separately. And then the medical practice then survives sort of on its own, and Galen becomes the next big figure in the 2nd century AD. Again, he's from that part of the world. I think he's a Roman citizen, but Galen is from Pergamum, which is in present-day Turkey, and he's kind of a major figure that revives interest in the Hippocratic texts themselves, which maybe had fallen out of favor for a couple of centuries. He revives them. He gives his own contributions. He makes his own contributions to the study of to at least to some theories of physiology and anatomy, and maybe and some corrections against what the Hippocratic physicians believed, and so forth. And so there's a body of text, and there are some schools in certain centers of learning that are established, over the centuries. But then the Roman Empire start to um, fall apart and fall into the decadence. Some of that knowledge is recuperated by Christian monasticism to a certain degree, right? Certainly, the Hippocratic tradition is viewed favorably. It seems to be consonant with the Christian beliefs. At least this the respect to the person, to the individual. It can be sort of Christianized or baptized into Christianity, and it is in a certain way. And so the texts, the Galenic texts, are kept, but it remains. I mean, it's in Europe, whether it's in the eastern part of the empire or in the western part of the empire. Uh, it's in rare centers of learning that stuff is taken up
Preserved. So
and
what happens to
preserved and whatnot.
medicine and physician practice in general in the West? Does it actually disappear, or
I don't think it ever disappears. I mean, I think the folk medicine will persist
takes
to some
over?
extent. It takes over. I don't know. I couldn't tell you sort of in economic term how much, what percentage or what proportion of practice or how much of it dwindled and whatnot. And I don't know that people know that. But but there's the emergence of something else, which is the emergence of the hospital that occurs in late antiquity, and it occurs in Christianity primarily. It's a Christian institution, and it's not. It's primarily a hospice more than a hospital the way we understand it, and it's not directly connected to medicine. It's primarily a hospice for the poor and the sick, to nurse them. I mean, they're kind of nursing institutions, but these are new. They did not exist before. They did not exist in the time of Hippocrates. Right? The Greeks did not have hospices. The Egyptians certainly did not. So the hospice is a Christian invention, and it will remain. It will be absorbed in monastic centers, monasteries over the centuries. There will be some monastic orders or some religious orders that kind of embrace, and in a sense, in many ways, sometimes corrupted the tradition of hospices. If you think about during the Crusades, and you have the Hospitallers and whatnot, and there's interesting, maybe I'm only vaguely familiar with it, but there's a lot of interesting stories of banking and money laundering that finds its way through the network of hospital communities and whatnot, and that sort of thing. But anyway, the hospice remains sort of separate and not so much. It's really a nursing institution, and until really the 18th or 19th century. But what happens is that then we have Descartes, which we've talked about Descartes in our first episode. So you have Descartes, and you have the emergence of iatromedicine, of iatrophysics, right? Iatromechanics, if you will, which changes the orientation of the practicing physician and makes him more aggressive. Because now the body is viewed really. I mean, you want to get to the part. You focus yourself on the part. If the part is not functioning well, you need to intervene a little bit more aggressively. You lose sight a little bit, to some extent. You lose sight of the fact that the body is self-healing, and so your interventions are going to be a little bit more aggressive.
I was thinking about how diagnosis comes around, and specifically thinking about, well, if diagnosis comes around at that point, and what existed before that. And I guess the obvious thing is nothing, because in part there was no need for the diagnosis before this development.
Right. The diagnosis, the term, the word diagnosis may not have existed, but I think the concept did exist. I mean, there were illnesses that had names. So in a way, the physicians did refer to various illnesses by various different names.
So I guess the point is, more specifically, what function did the creation of the diagnosis term
of the term of our diagnosis,
like, why did it originate? Like, what gap was it closing?
Right, in the 1600s.
Why was it created?
Correct. In the 1600s, I'm not sure. That's very interesting, but it's many medical terms of art emerge around that period of time. They emerge also because there is, during the Renaissance, there's a rediscovery of ancient Greek and Latin texts. So there's a revival of interest in um, in whatever systematic work was being done back in antiquity that was preserved but was not developed during the Middle Ages, right? It was preserved and passed on, but then with the Renaissance, there's sort of an enthusiasm to take these things a step further. So you have coining of terms of art, and maybe with the idea of being more systematic about this approach. You have a renewed interest in anatomy with Vesalius, with Da Vinci, um, and people like that. So you have to start identifying parts more specifically, more precisely. Then you get William Harvey and the a lot of the recognition that a lot of the body of knowledge that was sort of perhaps passively being passed on over the centuries was defective and needed to be revamped. Revamped with a more robust theoretical armamentarium and a more precise language. That's my guess. I mean, I don't know for sure. But you have medical practices, again, physicians separate from the hospital at the time of Descartes and beyond, but then they're more aggressive. They're more aggressive. Bloodletting becomes more aggressive. Purgation becomes more aggressive. There's a fellow in the Renaissance by the name of Paracelsus, who was an alchemist, a philosopher, a kind of a bombastic character. But he made an important discovery, which I think is important in terms of therapeutics and why the therapeutics became more aggressive also around the time of the Renaissance and thereafter. In terms of speaking of the agency of a disease, in the Greek mind, as far as I can tell, in the Hippocratic mind, when you have a disturbance, right, and you shake the body out of its healthy status into an unbalanced, unhealthy status, the agent is not necessarily, there's no notion that the agent is still present. Remember that they don't have the germ theory of disease, okay? So there is a factor, there is an agent force that disturbs. There's the miasma or whatever it is that throws off the body out of whack. And then the body will, it attempts to, find its way. But the body for them is still composed of the four humors, and the four humors themselves are the four elements. And there's nothing else in the entire world besides the four humors and the four elements. Okay? In the Renaissance, you have a questioning about this whole cosmology. And an interest, and a guy like Paracelsus becomes interested in metals and rejects the theory of the four elements and thinks that metals themselves have powers of their own. Okay? And so he postulates that diseases are caused by an ill effect of the agent that remains in the body. Okay? So if it's sulfur or whatnot, or one of these metals, okay, hence the interest in purging the body from whatever poison it has that remains in it, okay, hence the more aggressive stance towards bloodletting and whatnot. At least that's my understanding of the theory around that time. I'm pretty sure that's what it is. Maybe at some point I'll try to brush up on that, but I think to me Paracelsus is sort of an important hinge at that point in the thinking, whereas before a body was a body made of the four humors, and there was nothing intrinsically poisonous about what's in the body, even the body of a sick person. Whereas with Paracelsus, the poison is inside and remains there and needs to be sort of shaken out of the body.
It reminds me of how cancers were treated in the early years of the 19th and really still 20th century, where in the early years and even late, like as late as 60s and 1960s and 70s, like it just became increasingly aggressive.
Yeah.
Radical mastectomies and so on.
Correct.
If it's something that we can't quite pinpoint, then we just chop off as much as possible and catch it. in the process.
Right. And to to this day, there's an element of that, except that we hope, and to some extent we can be a little bit more pinpoint. Put some more pinpoint precision in where we are very aggressive. And so, if to the extent that we can be super aggressive and then extirpate, the part that is, violently take it out, we take it out, and then and I think there's value and merit to that. I don't think I'm not right. We there certainly is value to the germ theory of disease and the and toxicology, right? So Paracelsus is the father of toxicology, because toxins, he postulated the toxins were present in the body of the sick person. So, but anyway, so you still have kind of a parallel, two parallel institutions. You have the physician practices, independent physician practices, that remain primarily, general practices in the West, and you have the hospital, the hospices, and then the two get married, uh, really essentially in the 19th century, with the Paris school, the late 18th century, early 19th century, with the Paris school, um, because then, with the development of the science, and the science of, right, the mechanical science, and the application of chemistry and whatnot and things, the physicians needed to test their theories, and hospices or hospitals were a very efficient way of so they kind of inserted themselves into the hospice. And there was, and I don't know the details, but I know that there was some tension between the religious orders and the nurses and whatnot, who on the one hand were welcoming, wanted to have the the input of the physicians, but on the other hand there was some conflict in terms of, who's running the show here and whatnot. And eventually the nursing services would be displaced and the hospitals would be taken over by the physicians, and run by the physicians. And so that's what I have to say really about, sort of a broad overview, a 10,000 feet overview, with my kind of a sketchy knowledge of these things. But that's what I've gathered from my readings over the years.
I know happening parallel to this physician takeover or association was a really big qualitative change in hospitals, because in the 1600s and 1500s, they were, in addition to being religious institutions, they had a lot of support from wealthy families and so on. So I know there's records of like hospitals in Italy, for example, that they're described like extremely lavish. Like they're very nice, very well lit, very like accommodating. Like there's 3 meals a day. Like it's a place you want to be. And by the time you're in the 1800s, the hospital is probably the last place you want to be. Like it's awful. It's dirty. It's only hopeless cases go there. Often, it's a very drastic qualitative change over a short time span.
That's correct. So I have a book. I skimmed it, and that's what I mentioned when I talked about the the hospitals in the Middle Ages being not always pure relationship with the bankers and the wealth and the whatnot, because frequently it's very interesting, and I'd like to spend more time reading about it. But hospitals being centers of trust during the Middle Ages, during the during the Crusades, during that period of time when money had to be transferred from one place to the next, either by private entities or by state, princely or state entities or whatnot, the hospitals became kind of relays in a network where money
was like a Western Union.
Yeah, essentially, and attracted, and there was a lot, and they were also, of course, they were, in a tradition that believed in a perhaps in a too materialistically in ideas of what's the term, the indulgences, right, of buying your indulgences and whatnot. So hospitals, clearly wealthy people would give to hospitals, as they do to this day, but they certainly did in the Middle Ages. So you're correct. that hospices that were run by religious institutions attracted a lot of, could attract a lot of money and did attract a lot of money, so long as the church had a prominent place in society, and the religious orders had a prominent place in society, and so forth. And you're right. So after the wars of religion, with the Reformation, and then the dwindling, and then the Enlightenment, and the dwindling of the importance of religion, and the impoverishment of religious orders, the hospitals become poor, and they run on by charity that is no longer benefits from the big subsidies of either the state institutions or the wealthy donors for a period of time. And you're right that they become kind of decrepit, but they remained, and they had a role, and of course they still have a role. But that's the story. Okay, but maybe we will. I mean, it's been about an hour or so. Maybe we stop here. I thought it was fun. I hope people enjoy it. I'm glad that people are starting to ask questions on the comment section, and maybe we can encourage people to continue to do that, and that will give us some things to talk about.
Definitely, I'll try to. I'm thinking really. I think there's a lot of questions that need to be asked and answered about how these changes sort of change the way people interact with medicine, not just physicians, but like patients, and how society organizes around these different conceptions.
It'd be very good. Right. We could invite some people who know the subject. I mean, I know there are a lot of historians who specialize in the history of medicine, and they may enlighten us on certain aspects here and there.
Because I think that, like, just socially, the way we interact with the way patients interact with the system can vary drastically for even the smallest changes, qualitatively, but also just more generally. So, like, as a very quick example, doing video conferencing for patient visits is obviously more common right now during COVID. So, my mother had a doctor's appointment, and the doctor asked her to do a video call instead of just a regular phone call. And for my mother, it was a complete disaster.
Right.
Because she's, I would say, technologically savvy, but not completely comfortable with it. So the quality of her experience as a patient just completely dropped, because now she's nervous. She's afraid she'll screw something up. She's anxious the entire time. She asked me to help her out, just to be there. And, I was present. So it's the content of the meeting. There was no reason it couldn't have just been a regular phone call.
Right. Right.
So, small changes like that, that can have a huge difference.
Right.
And so what does a bigger change, like moving from small physician practices to a hospital-based system, what's the net impact for people of that system reorganization?
Right, for sure. But these things happened in the aftermath of huge societal upheavals, right? I mean, wars of religion, revolutions, change from one, political order to another. And that's something we certainly need to keep in mind, is that, medicine obviously reflects what's going on in the rest of society, for the most part, even though, and it is both, it reflects what happens, and it also bring about some changes, because in medicine, we're sort of at the interface between how, human beings view themselves, right? We inform people about what it means to be a human being, or a functioning human being in society, with our theories, depending on what kind of theory we have about health and disease. That will certainly have an impact. At the same time, our theories about health and disease they don't just come from us.
Right.
Just like for Hippocrates, I expect he was influenced by what was going on in society around him at the time that Hippocratic medicine emerged. Very interesting. Thanks for joining me. We'll pursue this further.
Look forward to it.
Okay.